Hello, I'm Sinead Brophy and I'm the Professor of Public Health Data Science at Swansea University. I'm also the Director of the Centre for Population Health in Wales, which brings together the Universities of Swansea, Bangor and Cardiff and Public Health Wales. I'm going to talk a little bit about how we use machine learning in our epidemiology work within the centre. In Wales, we use the SAIL data bank, and that's a secure, anonymised information linkage system, which brings together data from GPs, hospitals, schools, social care. However, with so much data, it can be very hard to tell the wood from the trees. What factors are associated with certain outcomes? Machine learning can help to identify patterns and clusters of associated factors that can predict certain outcomes. So one use of machine learning is to be able to consider all the data, but to reduce the number of factors that will be taken forward to be considered in a model. That's feature selection. This is looking at all factors that might be associated with an outcome and is not hypothesis driven, and is not even suggesting there's a causal relationship. For example, in many machine learning models, having childhood vaccines is associated with many of the outcomes we're looking at. This simply reflects that people who attend health services for routine vaccinations are more likely to attend their GP in the future and be picked up for outcomes we're interested in. There's no causal relationship, but it does tell us a lot about the bias in our data and who might be missing from our data sets. So this use of machine learning is hypothesis generating and is just looking for factors which are associated or predictive of a specific outcome. The findings from this can be taken forward to undertake traditional hypothesis-based analysis. However, machine learning gets a bit of a mixed press. We'd all recognise it in uses like Siri, which is a straightforward use of it. It uses neural networks in order to read voices to text. And the original voice was a real person, it was Susan Bennett. We'd recognise it in Amazon, which has taken on predictive analytics, seeing what you've looked at, what you like, clustering your behaviours, recommending things you might also like based on what other people have bought, and even predicting products that you're likely to buy in order to have them in the local warehouses. And then there's the more dubious use, like deep fakes, which shows people saying things that they've never said. However, in medicine, it's still treated like any new intervention, and predictive tools developed by machine learning still need to be tested under randomized controlled trials. For example, Google's DeepMind Health, which partners with the Moorfield Eye Hospital, has successfully trained on thousands of eye scans to identify 10 key features of eye disease, make a referral recommendation and the level of confidence around that referral, and say what features this is based on. It's 94% accurate compared to clinicians' comparison. The technology is now going through a clinical trial, but it could allow eye conditions to be spotted earlier and prioritise patients with the most serious eye disease. There's computer predictions on how proteins fold using the amino acid sequence, and that's been used to give structure predictions of the proteins that are associated with SARS-CoV-2 and that might help understand how they function for new mutation predictions. In terms of PREDICT, the project PREDICT, it's being used to take symptoms of depression and predicting which depression treatments will give the best response. And that's under RCT, randomized control now, in 5 European countries. The methods used in machine learning will always need an external validation, such as a randomized control trial, because what you get out depends on what you put in. So raw data generally has to be pre-processed to detect signals. So for example, there's about 150 pages of read codes of ways of defining different injuries. If we want to identify if a certain exposure is more likely to lead to injury, we can't leave the definition of injury to be 1,500 different ways of coding the same thing. We have to bring all the codes together to flag it so that you can go, this is an injury. But we might actually want a specific injury. So we would want to flag, for example, brain injury. and be able to identify if this occurs. The pre-processing will affect what we get out. For example, with medication, do you identify drugs by brand, dose, the active ingredient? If there is missing data, do we impute this or just look at complete cases? Is the fact it's missing actually a predictive feature in its own right, something we can use to identify people who have poorer outcomes, the fact that they're missing from GP treatment? What you show the machine affects what you're going to get out in the end. So the pre-processing and aggregation of the data has a huge effect on what you're going to get out. Transforming the data, splitting the groups, grouping other groups, all of this makes a big difference to the model you get in the end because it changes what signals what the machine sees. Machine learning is different from statistical traditional analysis where you specify in advance, this is what I'm going to look at, and you don't deviate from your protocol. With machine learning, you try one model, see how good it is, change it, try another model, see how good it is, keep tweaking and adapting the model, and only take your best models forward. So I'm just going to give some examples of how we've used machine learning in our epidemiology work. One method of machine learning is supervised learning, where you show the machine, this is disease, this is no disease, spot the difference. Like a clinician sees a lot of people with the disease and so can recognize the features of that disease. But when we do machine learning with routine data, we end up showing the machine a couple of million cases of normal and just a few thousand cases of disease. So we really are training it in identifying normal, whilst a clinician becomes very skilled and trained in identifying disease. And that's a problem because we end up with an unbalanced data set. We end up with 30 million normal cases and maybe 2,000 disease cases. For example, we wanted to see if we could distinguish between those with ankylosing spondylitis and those with mechanical back pain using GP records. However, if we use all the records in Wales, we would show the machine potentially 1 million people with mechanical back pain and only about 4,000 with ankylosing spondylitis. So it would actually become very trained and very good at recognizing mechanical back pain rather than ankylosing spondylitis, and that wasn't what we were trying to achieve. So we started off with looking at what features were there that we should take forward to explore the difference between ankylosing spondylitis and mechanical back pain. And initial analysis showed that the presentation for males and for females was not the same. Women had more pain medication codes and had less back pain codes. So the first decision we made was to do separate models for males and for females. We needed to make sure it really was ankylosing spondylitis, so people had to have their diagnosis between the ages of 15 and 35, and they had to have enough data before their diagnosis for us to identify codes that could be predictive and would proceed to the diagnosis. And we had to have matched controls so that we didn't have this unbalanced data set that I was talking about. So we needed 100 mechanical back pain controls for every one person with AS. And not every person with AS were we able to get 100 controls who were age, sex matched. So these criteria means we were down to 1/10 of the numbers we started with. We ran every read code, every ICD-10 code, medication codes, grouped medication codes, procedure codes. And so we're talking about 280,000 different combinations. And we identified about 900 variables that were either associated with AS or associated with mechanical back pain. And then we took each of these and ran principal component models so that we could figure out which ones to take forward. And then each of these principal component models were combined into a decision tree to find the best model to select. So for example, a person's medical history would be run through one model, principal component A, and this includes things like number of diclofenac tablets taken between the ages of 15 and 20. Have they had a plain radiograph between the ages of 15 and 20, but not had one when they were aged 30 to 35? Is there no rheumatoid factor? So if they had a test and it's absence for rheumatoid factor, given a certain threshold, they would, if it was high on this, they would move to be, we believe this is likely to be ankylosing spondylitis. If they were low on this, they'd run through a new model, principal component B, which for people who do have rheumatoid factor, then looks at do they have back pain without radiation and many other features. And so the medical history is run through different principal component models, and given the threshold it reaches, a decision is made whether this is ankylosing spondylitis or not ankylosing spondylitis. This will generate different models depending on what we say is important. So for example, if we say the positive predictive value is the thing we want to prioritize, as in if we say this is AS, it really is AS, then we would be finding rare codes associated with ankylosing spondylitis. So things like a family member has AS. So we'd be selecting the rarer codes to be sure this is AS. However, if we choose a different method, for example, the F score, then we'd be predicting the most common things that people with AS present with. So we would be selecting codes more about swollen peripheral joints or things which are very common to people with ankylosing spondylitis, but that may not be as good in terms of a positive predictive value because these may be common for other conditions too. So we end up with something like, in the AS male population, there were three main groups. Those under the age of 20 who had lower back pain from a young age and were on medication for pain, and many of these also had developed uveitis in their 20s. Group 2 were people aged between 20 and 25 who'd had back disorders, had been on many NSAIDs and had many blood tests. Group 3 were those aged 25 to 30 who'd had numerous blood tests, various musculoskeletal codes, clear back pain codes, and had had radiology. Now this model, if people's medical records were run through, appeared to have excellent performance with about 76 to 78% positive predictive value, but that's within the test sets, and that's completely equivalent to other publications in this field and is equivalent to predicting ankylosing spondylitis using other methods. However, in this test data set, we had 1 in 100 people who had AS. So we have slightly higher than in the real world. If we applied this to a general population, only about 0.09% of the population in the GP data we had ankylosing spondylitis. So the positive predictive value of this test, even for the best test we could have made, would only ever be about 1.4% because it's so rare in the GP dataset. So what we actually need to do is develop a model to detect suspected AS, like this one. Then the person might need to be referred for further tests, like a B27 test. Their symptoms might be monitored so we can build a new model which incorporates the symptoms. But this would be a group where there's a higher proportion have AS. We would run a new model on this higher prevalence of AS. And perhaps then that would highlight a few who we think have suspected AS again, and we would need to run it again where there is a higher prevalence of AS in the new group as well. So what we would be needing is repeated rounds of models which slowly increase the percentage of the population with AS so that the positive predictive value increases in each successive round. This method of a series of progressive models slowly honing down the likelihood of AS is probably the only way we could progress with this. And having done that, we would then need to develop a randomized controlled trial to show that it actually does predict people who will go on to be diagnosed with ankylosing spondylitis. Another method used in machine learning is unsupervised learning. In this, you're not telling the machine what to find. You're looking for what clusters or what it finds from the data you give it. You're asking it, what patterns are there? So for example, we looked at what codes were present after a teenager was given an antipsychotic prescription compared to before their prescription and compared to controls and their before and after. So what codes were more common after a prescription? And what we found for teenagers given antipsychotic was there was higher rates of depression codes, injury codes, respiratory infection codes, diabetes and epilepsy. So we used one set of data to be able to see that these codes clustered after a prescription, and then we used a second set of data to explore these codes more and to look at what are the prevalence rates. So the machine learning simply highlighted to us these are areas we should look at, and then we go and use traditional statistics to look at that in more depth. When using more traditional statistics, we can see that the rate of going into hospital for respiratory infection before a person is put on antipsychotic was 2.8 per 100 people. And this was already twice as high compared to people who are not put on an antipsychotic, who had a rate of 1.3 per 100 people. After time, the controls, the people who weren't put on an antipsychotic, have a lower rate of being hospitalized for respiratory infection. And this is as they get older, they probably have less respiratory infections. However, those given an antipsychotic, after they're on their antipsychotic, their rate does not fall, and they are at the same risk of getting being hospitalized for respiratory infection, which then puts them at 3 times the rate compared to those not on an antipsychotic. So if we divide the rate after antipsychotic, which is 3 times that what you'd expect, compared to the rate before, which was 2 times what you'd expect, you can see that they're about 50% more likely to be hospitalized for a respiratory infection. Antipsychotics are known to affect swallowing and to reduce swallowing. So this may then make it unsurprising that it's associated with respiratory infection. We also found that people on antipsychotics had more diabetes associated codes, and this may be because antipsychotics are associated with weight gain. And we also found that people who had epilepsy had more seizures, and it's known antipsychotics reduce the seizure threshold. The real finding for us was that machine learning did appear to find real signals, which were then supported when we used traditional statistical methods. It identified also that the antipsychotics were given more to children with intellectual disabilities rather than those with psychosis. And although it was associated with higher rates of respiratory infection, epilepsy and diabetes for all, it was those with the intellectual disabilities where there was more injury and more depression after taking the antipsychotics. The study also identified that people with intellectual disability were more likely to be prescribed them at a younger age and prescribed them for a longer period of time compared to people who didn't have an intellectual disability and were prescribed antipsychotics. I'd just like to present briefly another study which will be given in detail this afternoon by Delia Putney, and this is her research, and I'm just going to present a little bit about her background. She was looking at analgesic prescribing across Wales. Analgesic prescribing in the UK is increasing. Overall, opioid prescriptions for non-cancer pain appear to have stabilised, but the percentage of strong opioids is increasing. And from ONS data, opioid-related deaths have also been increasing since 2012. Strong opioid prescribing is associated with multiple factors, including deprivation, mental health problems, age, gender, comorbidities. In addition, there's a real geographical variation. As you can see from this heat map here, that the northeast of England has some of the highest rates. However, analgesics are often prescribed for chronic pain, which is extremely complex. Delia used unsupervised learning or cluster analysis to group primary care practices by their demographic profile, deprivation and disease profiles. And then the cluster type of practice can be used to look at analgesic prescribing by practice type. Essentially, she identified 3 clusters or 3 different types of practice, which differences in rurality, age profile, disease profile, and deprivation levels. So these clusters can be used to compare similar practices for their analgesic prescribing rates. So in this group 2, you can see are slightly older, more likely to be living in a village, so more rural, and less deprived, compared to group 1, who are slightly younger, who are more likely to be urban and more likely to be deprived. And as you can see, group 1, where they are as urban, younger, deprived practices, have the highest prescribing level. And this then begs the question that if national targets really are applicable to all practices, or if they should account for the different populations served by the different practices. Delia will be presenting more about this and more detail about this afternoon. I just want to show how different methods in machine learning can be used to understand where best to target prevention methods within public health. So if we look at school readiness, if we're interested in helping more children be ready for school, we can use a method called decision trees. And what this does is it splits the data in half with the variable that identifies the biggest difference between those who are school ready and those who aren't. And what it finds initially is male gender is the variable that causes the biggest, what's called information gain, but basically split between who's school ready and who's not. And boys were 50% less likely to be school ready compared to girls. Then it splits again on the variable that makes the most difference, and deprivation was, so children who were more deprived, again, were less likely to be ready for school than the non-deprived children. And then the next split it did was on school attendance in the early years, so in nursery. So the decision tree method would suggest that prevention methods should be aimed at boys living in deprived communities and really should be providing nurseries for early years attendance before children get to school. If we use a regression method, what we would find is what is the variable with the largest odds ratio. And in this case, maternal learning difficulties has the largest odds the child will not be school ready, but it doesn't affect very many children. Only 0.14% of children would have a mum with learning difficulties. The next variable with the highest odds ratio would be a child with epilepsy. Again, this is very uncommon, with only about 0.4% of children having epilepsy, but is a very high risk factor that child will not be school ready. So these factors, using a linear regression, will help identify very high risk individual children where help and support can really help that family. Sometimes we use machine learning to explore the data we have and the patterns. And although what we find is really interesting, it's hard to know how helpful it is, really. So for example, in trying to see what read codes might a GP use to identify long COVID, we can see that people who had a COVID test and were positive and people who had a COVID test and were negative. How do we identify people who may have long COVID? Well, using the machine learning method, it suggests that they have telephone calls with a GP for a much longer period of time. Is that helpful? I don't know. It is probably true, but I don't know how helpful it is in recognizing long COVID. In looking at people who are readmitted to hospital after having an admission for Campylobacter, the profile of people who get readmitted are generally people with ingrown toenails, unhealing wounds, and many factors which are associated with low self-care. However, I'm not sure how useful that is to explain that if somebody's being discharged from hospital, but they've previously had a history of ingrown toenails and unhealing wounds, so they should be given a lot of extra help and support so that they take their antibiotics and so that they are not readmitted to hospital. So I just want to summarize how we've used machine learning in our epidemiology work. My take-home messages would be that it's actually very useful to understand the flaws in your data and to understand your data much more. How good it is really does depend on how you use it. And you have to remember that missing data or dirty data will be interpreted as features and will be interpreted as predictive things in your model. And so really black box methods may have problems within public health. The data has to be weighed to improve interpretation. For example, one diagnosis of cancer needs to be treated as much more important than 150 measures of cholesterol. How you weigh it affects your findings in the end. The clinical interpretation is needed really to aggregate the data so that the data is cleaned or aggregated in a way that makes sense. For example, methotrexate dose. Do you just flag methotrexate? Do you include the dose because it's going to be different between cancer and arthritis? So there is a bit of an art in it. There will always need to be RCTs and longer term follow-up studies to evaluate predictor tools as with any intervention. So it's a very useful, helpful tool, but it needs interpretation, needs to be used in the right way, and will always need validation. I just want to end now and say thanks to the senior analysts and researchers who did all this work. That's Jonathan, Amarita, Shangming, and Delia, who you're going to see this afternoon presenting her research. And finally, here's a bit more information if you want to read more about the research that was presented in these slides. Thanks very much for listening.